Next speaker will be Prof. Gert. He's known figure in IBD field. He has a lot of research, and in regard of IBD, he's division head of gastroenterology department at the University of Leuven in Belgium. Floor for you.
Thank you very much for the kind invitation to the Kingdom, to this distinguished symposium. It's an honor and a pleasure being here. It's my first time in the Kingdom, but it's a very nice experience up to now. Yes, thank you very much. So I've been asked by the organizers to speak about the approach to visualizing Crohn's disease, and I will try to keep it as clinically relevant as possible. First of all, some definitions and some anatomy. When we're talking about fistulizing, or sometimes called penetrating Crohn's disease, you have to know where the word comes from the Latin word of a little flute, which is a fistula, and it's actually an ulcer penetrating in the surrounding tissues. That's the definition. And very broadly, we can distinguish intracutaneous fistulas and intra-abdominal fistulas. I will focus most on the intracutaneous fistulas, which can be both perianal or to the abdominal wall. And the rectovaginal fistulas are a little bit between both, because they're not intracutaneous, but they're associated often with intracutaneous perianal fistulas, so that's why I'm going to discuss them with the perianal disease. As Remo said before, what we've been doing all over for the last 20 years is doing a step-up care, starting low, and medications that we might not suspect that are not so efficacious, but that's how we did our clinical practice in Crohn's disease. So we used antibiotics as a first-line treatment in perianal fistulizing disease, mainly to control pain and sepsis, and we know there's some intolerance associated with them when we use them long-term, both with the nitroimidazoles and with the quinolones. Then we have the thiopurines that we've been using a lot in perianal fistulizing disease. Actually, if you look at the data, the evidence for them to use them is low, and you know they have an infectious and malignancy risk. Infliximab and adalimumab are the two anti-TNFs that have been tested for perianal fistulizing disease. Infliximab with a little bit more evidence than adalimumab, but we're using both in clinical practice. To be honest with you, their efficiency and if you look at it, not just for the efficacy, but the efficiency standpoint, is moderate. They have a 23% short-term remission rate. When you give them for 1 year, 50% of the patients will relapse. And when you stop the treatment, 67% of the patients will relapse. And of course, they have an infectious risk. And when you combine it with thiopurines, they also have a malignancy risk. Surgery, both drainage and restoration, has a moderate efficacy. There's no really good control trials, but if you look at big cohorts, prospective cohorts, there's anything between a 25 and a 64% closure rate with, for example, an advancement flap. But if you have operations too many times, there's the risk of anal incontinence. The most drastic solution to perianal disease is proctectomy, which has a high efficacy, that is clear, and it also, and that is very important to remember, eliminates cancer risk. We detected 2 cancers in the last 2 weeks in chronic perianal fistulas at our institution. So don't forget about perianal cancer, both squamous and adenocarcinoma in long-standing fistulas. But of course, for patients, this option of proctectomy is highly mutilating. First little case for you. This is a 20-year-old patient with perianal fistulizing Crohn's disease. He reports having actively draining fistulas or fistula openings despite ciprofloxacin and azathioprine. He has pain and a CRP at 50 milligrams per liter. So what would you do now? Would you start adalimumab? Would you start infliximab? Would you explore surgically with an examination under anesthesia, or do something else? I'll try to convince you that both C and D are the best options at this time. Why? Well, I heard there has been some snow in the Kingdom in the last couple of days, but let's say this is a beautiful snow-capped mountain somewhere in the Swiss Alps. Well, the patient has pain, swelling, discharge, and fever, and that is what the mountain shows you. That's the superficial symptoms. However, you need to realize that most of what is happening and is going wrong in perianal fistulizing disease is down below the surface. So we need to come up with better ways of showing what's going on, the full picture. And this is the very patient I introduced to you, the 21-year-old male patient. This is serial MRIs in this patient of the pelvic floor. And you see that the patient has been using infliximab week 0, week 10, and week 46. There's two very important messages associated with this slide. First of all, if there's still a lot of pus, and you see why they call it a horseshoe fistula. If I get my arrow here, it's a clear horseshoe. I know how important horses are in the kingdom. That's why they call it a horseshoe fistula. If you treat a patient with an extraceton, you can see here that the surgeons put in an extraceton. Still, there's, after 10 weeks of infliximab, still some intense material left. It's only after 46 weeks that there's no residual hyperintensity, no residual inflammation. The two messages is, first, map the disease, drain the extra sepsis, and second, treat long term. It's not a one-shot single treatment therapy that will help you with perianal complex fistulizing disease. Why is that? The anatomy is so complex. On the left-hand side in green, you see all the potential localizations for abscesses, so they can be extra-sphincteric, intersphincteric, above the levator plate, which is very feared by the surgeons, and also very superficial, which probably doesn't need a lot of medical treatment, just small incision, because it's not penetrating here the fistula apparatus. And the fistula tracts that coincide on the right side with those abscesses are also very complex and can be penetrating both sphincters, and can create a lot of trouble for the patients. So what I'm going to talk to you about is combining your efforts when you treat perianal fistulizing disease. You need to sit down with surgeons, radiologists, gastrologists, your IBD nurse if you have one, and a pathologist. Remember what I told you, beware of the cancers, to inform you about the histology of what you're looking at. But it is a combined effort. Another short case, a 36-year-old male was diagnosed with Crohn's disease 13 years before, had ileal and rectosigmoidal disease location that had been shown at endoscopy. And then he reports perianal pain, red bulging skin, fever, and he received antibiotics from the GP, and spontaneous pus drainage had occurred a few days before they come to your practice. What's your advice now for him, to him for a diagnostic workup? You could send him for examination under anesthesia to your surgeon, have a flex rectosigmoidoscopy done. You could have a pelvic MRI first and then an exploration surgically if needed. You could do a pelvic CT first and an exploration if needed, or an endoscopic ultrasound first and then a surgical exploration if needed. There's a lot of options you could do. There's no 100% answer, but this is an interesting algorithm that was published out of the European Crohn's and Colitis Organization and the IOIBD, and Christina Gert from Hungary is the first author. You see that physical examination is still the first thing you need to do. And then you try to differentiate. If there's fluctuation, you suspect an abscess. If there's a stricture, you feel that at the rectal examination, there's another way to go. Let's say that in our patient, our 36-year-old, we're on the right-hand side, no fluctuation, no stricture. Then you would go for an MRI or an endoscopic ultrasound, whatever is best available at your center, and an endoscopy, because you need to know whether there's deep ulcerations in the rectum. And then you go for a surgical exploration with or without a ceton. If you suspect or feel a stricture, endoscopy is the first step to take, plus a dilation if possible, endoscopically using a Savory or another material at a gentle dilation can be done, and then examination under anesthesia plus or minus a ceton. When there's a clear fluctuation, so you almost feel the abscess, I think there's two ways to go. Either you drain the abscess first by the surgeon, or you do an MRI to map the full disease. If you have had an MRI before, you don't have to do it again, but otherwise, after the surgical exploration, think about an MRI or an endoscopic ultrasound, and have an extra ceton placed when the MRI still shows sepsis. So you see that you need to invest in clear mapping and in surgical drainage before you embark on your medical therapy. We published about 13 years ago an MRI-based score of severity that has both anatomy and inflammatory activity components. Both are important. It had a good inter-observer agreement, operator independent. It's been used in other retrospective studies, but it's never been externally validated. And at this time, actually, the Robarts Institute is working on this score to try to make it better and more sensitive to change. Why is that? We published, and also St. Mark's at around the same time, using our score or the components of it, that the score does go down when you treat with an anti-TNF agent, but the most gain you're getting initially. Afterwards, the score doesn't go down completely to zero. Is that because the score was not completely well designed, or because there's always some residual signs of disease in the perianal space? We'll have to see when the scores are being looked at again. Local techniques to increase the fistula closure. A lot of press has been around all these accessory techniques, specifically in the surgical literature. First of all, fibrin glue has been used, but mainly, to be honest with you, in an uncontrolled setting, small case here. There's been one French randomized controlled trial, which was open label, with using glue or just observation in perianal fistulizing disease. Success was 11 out of 36 in the patients with fibrin glue, but they had 4 abscesses in this population. So fibrin glue can give rise to locking up the sepsis and, again, abscesses. Fistula plug, I'll be short about. There's mainly uncontrolled small series, so I don't think the surgeons are using still a lot of fistula plugs. The new kid on the block has been the mesenchymal stem cells. Makes sense. You want to maybe reintroduce cells that will actively close your fistula. Well, there has been one randomized control trial from Spain with autologous stem cells, fat-derived, adipose tissue-derived. That was not just Crohn's disease, there was also sporadic fistulas in the cohort. And another study with 23 patients, but that was just a prospective case series. This is a very new data. It's not been released. It's on the website of the company. It will be presented by Dr. Julian Panes at the European Crohn's and Colitis Organization Symposium in Amsterdam and later at the DDW. This is using autologous stem cells, fat-derived, in a controlled setting. This was done in Europe. And you see that baseline MRI was taken at the primary endpoint. It was a surgical medical approach. The primary endpoint was at week 24 and was both clinical remission, so no drainage at gentle compression, and MRI remission. And the gastroenterologist evaluating the patient and the radiologist was completely blinded to what the patient had gotten locally, either placebo injection into the fistula tract or the stem cells injected into the fistula tract. And this trial was positive. The stem cells provided more relief for the combined endpoint, and it was consistent over the rest of the secondary endpoints, and the trial will be presented in 2 months' time in Amsterdam. So something to look out for. Very early data still. There will be another trial in the US, but I think a glimpse of hope for this very refractory patients, that the future may be brighter than it is now. Rectovaginal fistulas. We have to be careful here, because if we're going to treat them, we need to map even more than in simple intracutaneous fistulas. On the left side, you see the picture of a seton through a rectovaginal or rectovulvar fistula, which gave a lot of symptoms to the patient. And if you look at the anatomy on the right, it's a straight line. It's 1 centimeter or less, sometimes 5 millimeters of a tract that you're not going to close with any anti-TNF agent, because it's a straight line. You need some surgery here, for example, a rectal advancement flap. If you're looking at a complex rectovaginal fistula coinciding with a perianal intracutaneous fistula, you're looking at this sort of pathology, and it's completely different. Here you can use adjunctive medical therapy to help you close this complex fistula trajects. For example, look at the experience that we had in Leuven with our abdominal surgical colleagues. You see that prior anti-TNF or no prior anti-TNF for a rectovaginal advancement flap for the success rate didn't make a big difference. If you tried anti-TNF after the flap had failed, which happens in about more than 50% of the patients, it's useless to use an anti-TNF. So it's a combined therapy when there's an indication, rectal disease or complex fistulas. It's not a rescue therapy. And this comes out of most of the cases. This is a meta-analysis of most of the cases of rectovaginal fistula and the use of infliximab here. There was no adalimumab data. And you see that it's a very variable and low efficiency. I think here you need to use it just as an adjunct to heal out the rectum and to increase the risks of surgery success. Let's move shortly, for the last part of this presentation, to abdominal and abdominal penetrating fistulas.
3 minutes more.
Different. I need 2 more minutes. Is that okay? So this is a case of a patient with a fistula that was penetrating to the abdominal wall. You see here that it's been drained and referred to our Center for Further Care. We did an endoscopy. We found this stricture and said this is not going to be dilated because it's already penetrating. If we dilate this, it's going to open even more. The patient had a very elaborate left-sided hemicolectomy with a transversal rectostomy, and this helped him. We just excised the fistula traject. But this is another patient that presented to us with a multilocar mesenteric abscess that you see here. When I find my arrow back, well, whatever, it disappeared. But you see the abscess clearly underneath the abdominal wall. We gave them IV antibiotics, and they were not improving. What we saw on the MRI is a very complex, elaborate ileal disease. Together with the surgeons, we decided not to do a resection because we were going to lose too much bowel. And this patient was treated with an anti-TNF and did very well over several years. So the main problem here is that you need to decide, of course you need to drain the septus and give antibiotics, and then see whether you go for surgery with resection or with a conservative medical option. And really, you need to know whether there are critical strictures. As Remo showed you, don't try to open a critical stricture that is fibrotic. Or if there is an overt bowel perforation with a fistula, you need to most often do surgery. Otherwise, you can stick with the antibiotics and anti-TNFs. So the learning points for this presentation are that the treatment of perianal fistulizing Crohn's disease is a multidisciplinary effort with surgeons, physicians, and radiologists. You need careful mapping with imaging guiding the treatment plan. Infliximab and adalimumab with drainage of sepsis and surgical care provide optimal results, and new local treatments should be explored further. And intra-abdominal fistulas, finally, and abscesses are mainly a surgical indication when they are symptomatic. Thank you very much.